You are staring down the barrel of the FRCS plastic surgery board exam. You've memorized your flaps, you've drawn out the brachial plexus until your hand literally cramped, but now you're looking at a clinical scenario involving a wildly deformed hand. And the examiner is just sitting there waiting for you to make sense of all this chaos.
Yeah, and usually when we approach a surgical diagnosis, there's a certain mechanical predictability to it, right?
Right, like a bone is broken or a tendon is severed.
Exactly, you just fix the structural failure. But the rheumatoid hand, it forces you to be way more than just a carpenter. You have to be a rheumatologist, an immunologist, and honestly, a biomechanical engineer all at once.
It's basically the ultimate test of understanding systemic biology driving localized mechanical collapse.
Oh, absolutely. You're looking at a biological engine that's just actively dismantling the hand's architecture.
So, to make sense of that chaos, you really need a blueprint. And today, our blueprint for this deep dive is the MedSyncLimited.com FRCS Plastic Surgery Anki deck.
The lifesaver, honestly.
It really is. We are taking those 7,000 questions, which are, arranged by topic to turn passive revision into active recall.
And based on the textbook, Keynotes in Plastic Surgery, which is huge.
Right. It is the absolute go-to companion exam question guide. And we're pulling purely from the rheumatoid hand section today. No fluff, no long stories, just the high-yield mechanisms. So let's just get straight to the point.
Let's do it.
What is the fundamental triad of rheumatoid arthritis we are looking for? And who is the classic patient sitting in that exam chair?
Well, the underlying triad is persistent synovitis, systemic inflammation, and the presence of autoantibodies. That's the triad driving all that structural collapse.
Okay. Persistent synovitis, systemic inflammation, autoantibodies. Got it. And the demographics.
Board exams love classic presentations, right?
Right.
So you're looking for a patient around 70 years of age. That's the peak incidence.
And mostly female, I'm assuming?
Yeah, heavy female predilection. 3 times more common in women, actually. And crucially for us in plastic surgery, over 90% of these patients will have hand of them.
Over 90%. So it's basically a guarantee you're going to see it in the upper limb.
Pretty much, yeah.
Is this just an inevitable genetic cascade for these patients, or do environmental triggers play a part?
It's roughly a 50-50 split. Half the risk is genetic. The specific genes you really need to recall are PTPN22 and the human leukocyte antigen genes, or HLA.
HLA, right.
But that genetic susceptibility, it needs a spark. So smoking, for example, is a massive environmental trigger.
Really?
Smoking.
Oh, yeah. It literally doubles the risk of developing the disease.
Wow. Okay. Well, I want to understand the diagnostic markers we're looking at before we even think about picking up a scalpel. We constantly hear about rheumatoid factor, RF.
Right, which is essentially an IgM or IgA antibody attacking the FD portion of our own IgG antibodies. Exactly. But the Anki deck stresses that we actually prefer ACPA. Why is that? I mean, is it just a newer test, or is it fundamentally telling us something totally different?
It's telling us something way more critical. So ACPA, which stands for anti-citrullinated protein antibody.
Anti-citrullinated protein antibody, right?
It's vastly superior to RF because it's both more specific and more sensitive. But the real reason we care, especially as surgeons, is that ACPA is a powerful predictor of poor prognosis.
Oh, interesting.
Yeah, if a patient is ACPA positive, it signals a much higher likelihood of severe rapid joint destruction.
So what is actually happening inside that joint to cause all that destruction? Because it isn't just normal osteoarthritis wear and tear, right?
Not at all. No, it's a highly active cellular dismantling. You have these macrophage-like synoviocytes, and they become totally hyperactive.
And they start pumping out cytokines.
Exactly. They pump out TNF-alpha, which is the primary cytokine driving the whole process. And then you also have interleukin-1 and interleukin-6 amplifying that inflammation.
Oh, so it just snowballs.
Right. And this creates what we call a hyperproliferative synovitis. It's this thick, inflamed tissue that physically erodes the articular cartilage and the bone underneath it.
Man. Okay, so knowing that biology, how does it translate into the 2010 ACR-EULAR criteria? Because I know a patient needs 6 points for a formal diagnosis, but I'm always confused by how these points are weighted.
Yeah, the weighting can be tricky.
Like, why does having more than 10 joints involved, with just one of them being a small joint, instantly give you 5 points?
Because the small joints of the hand and foot, they are the absolute epicenter of rheumatoid pathology. If the disease has spread to that many joints, and it includes the small ones, the biological pattern is just undeniable at that point.
That makes sense.
Yeah, and from there, a high positive RF or ACPA titer adds 3 points. and symptom duration over 6 weeks adds another point.
But there's a massive shortcut on the boards, isn't there? Like a scenario where we don't even have to bother adding up the points.
Yes, absolutely. If you order an X-ray and see typical rheumatoid erosions, the patient is instantly classified as having RA.
Boom, done.
Exactly.
Yeah.
The structural damage acts as definitive proof of the biological process.
So let's visualize that X-ray for a second. If I throw a film up on the light box of an inadequately controlled rheumatoid hand, what are the undeniable hallmarks I'm looking for?
You're looking for 4 specific things. First is joint space narrowing, which, can eventually progress to total ankylosis or fusion.
Right.
Second, juxta-articular erosions. These literally look like a bite was taken out of the bone right next to the joint, exactly where that inflamed synovium attaches.
I have a rat chewed on it?
Basically, yeah. Third is soft tissue swelling. And fourth is generalized osteopenia.
Wait, hold on. Why generalized osteopenia? I mean, I get why the bone right next to the inflamed joint gets weak, but why is the whole hand losing bone density?
It's actually a combination of 2 things. Locally, you've got the systemic inflammation and cytokines disrupting normal bone remodeling. But mechanically, think about it. Because the hand is so painful and swollen, the patient just stops using it.
Ah, disuse.
Exactly. That lack of mechanical loading leads to disuse osteopenia across the entire limb.
That makes perfect sense. Okay, now before the examiners actually let us pick up a scalpel, they always test syndromic associations. We're expected to look way beyond the hand.
Oh.
So what are the classic triad syndromes we need to recognize?
You must memorize 3 specific associations. First is Sjogren's syndrome. That's the triad of dry eyes, dry mouth, and RA.
Because it attacks the exocrine glands, right?
Sure, exactly. The autoimmune process infiltrates those moisture-producing glands. Second is Felty's syndrome. That's RA key, combined with an enlarged spleen and neutropenia.
So the white blood cells are just getting trapped in the spleen?
Yeah, they're essentially pooled and destroyed in there. And the third one is Kaplan's syndrome. That's RA combined with pneumoconiosis. It presents as these large nodules in the lungs.
Got it. Now, I've also seen questions about renal failure in these patients. Is the rheumatoid arthritis, directly attacking the kidneys?
That is a classic board trap. Do not fall for.
Oh, really?
Yeah. Kidney involvement in RA is almost always secondary. It's not the disease directly attacking the nephrons.
So why do they fail?
They fail either as collateral damage from the heavy-duty medications used to treat the RA or from secondary amyloidosis.
Secondary amyloidosis, meaning the chronic inflammation causes the liver to pump out all these proteins that misfold and just clog up the kidneys.
Precisely. It's the systemic exhaustion of dealing with constant inflammation. Oh, and also during your physical exam, you should always check the elbows.
Why the elbows?
Because rheumatoid nodules love to form over pressure points like the olecranon. Chronic mechanical pressure really exacerbates that focal inflammation.
Good tip. So the rheumatologists, they're trying to stop all this with medication, right? The goal is to induce remission. What does that first line of defense look like, and what are the testable side effects we need to know?
The first line involves DMARDs, disease-modifying antirheumatic drugs. The 4 you need to know cold are methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine.
Methotrexate, sulfasalazine, leflunomide, hydroxychloroquine, and the side effects.
The classic triad of side effects the examiners will go after are hepatotoxicity, blood dyscrasias, and interstitial lung disease.
And if those fail to stop the structural collapse, then we bring in the biologics.
Right. That's when we target the specific cytokines we talked about earlier.
Mm.
For TNF-alpha inhibitors, you're looking at adalimumab and etanercept.
Okay.
And for an IL-6 inhibitor, the classic choice is tocilizumab. And it's a quick clinical pearl here. These patients take a ton of NSAIDs for pain. You must always co-administer a proton pump inhibitor, a PPI, to prevent severe gastrointestinal ulcers.
That's a great pearl. Okay, here is where my surgeon brain finally kicks in. With all these incredible drugs pulling the disease into remission, when do we actually step in? If a patient comes into my clinic and their hand is severely deformed, ulnar drift, swollen knuckles, but they tell me it doesn't hurt and they can still button their shirt, do I operate to straighten it out?
Absolutely not.
Never.
Never. That is the absolute contraindication for surgery in a rheumatoid hand.
Mm-hmm.
A pain-free hand with good function. You never operate for cosmesis alone in this scenario.
Because we'll just make it worse.
Exactly. Surgery will inevitably introduce scar tissue, stiffness, and potential complications. You could very easily take a deformed but functional hand and turn it into a straight but totally useless block of wood.
Wow. That is a stark warning. So when we do operate, what is our hierarchy of goals?
There are 4 indications, and they are strictly prioritized.
Wow.
Number 1 is pain relief.
Pain relief. Okay.
Number 2 is the improvement of function. Number 3 is prophylaxis,
Prophylaxis meaning like preventing a tendon rupture.
right? Intervening to prevent a tendon from snapping or a joint from completely dislocating. And then number 4, dead last, is cosmesis.
To achieve those goals, we have Willie Suter's famous winners, right? These are the procedures that reliably work in RA.
Yes, Suter identified 4 winners: fusions, extensor synovectomies to protect the tendons, Darik's procedure at the wrist, and MCP joint arthroplasty, which is usually done with silicone implants.
But we can't just dive right into the hand. The Anki deck emphasizes a very specific staging rule.
Yes, the golden rule of rheumatoid surgery is to always start proximally. You have to address the shoulder and the elbow before you even think about the wrist and fingers.
Okay, I have to challenge that.
Yeah.
If a patient is sitting there complaining that they literally can't pinch their fingers together, why on earth am I evaluating their shoulder?
I know, it seems counterintuitive, but think about the biomechanics of their daily life. Many RA patients have lower limb involvement too, right? Bad hips or knees.
Right.
Which means they rely heavily on walking aids like crutches or frames. To use a crutch, your shoulder and elbow must be able to bear your body weight and position your hand in space.
Oh, I see where this is going.
Right. If you beautifully reconstruct their delicate finger joints, and then they stand up and shove all their body weight through those new joints to use a crutch because their shoulder is shot, they will destroy your reconstruction in a matter of weeks.
Oh, wow. Yeah.
So the upper limb cascade of involvement is elbow, wrist, MCPJs, and then PIPJs. You just have to build the house on a stable foundation.
That is a brilliant way to conceptualize it. The hand is just the end of the mechanical lever. Okay, so following that proximal to distal rule, let's look at the wrist. It's the foundational block of the hand.
It is.
Let's unpack Kaput-Ulnay syndrome. We see volar subluxation of the carpus, volar subluxation of the extensor carpioulnaris, and supination of the carpus. So the ulnar head is left sticking out dorsally, creating that classic piano key sign.
Right, where you can press it down and it just springs right back up.
Exactly. But why does this specific collapse lead to tendon ruptures?
Because of the destructive physics of carpal translocation. When the wrist bones slide all gnarly and drop volarly, they physically drag the extensor tendons out of their natural grooves.
Right.
So these tendons are now pulled directly over the distal ulna. But remember, this isn't smooth, healthy cartilage anymore. The synovitis has eroded the bone into this rough, jagged stump.
Oh, man. So it's essentially a frayed tension cable dragging back and forth across a jagged rock.
Exactly. And that friction causes von Jackson syndrome.
Von Jackson, that's the progressive rupture, right?
Yes, the progressive sequential rupture of the extensor digitorum communis tendons. And because of the anatomy, it always sweeps from ulnar to radial.
Oh.
Always.
Yeah.
The first tendon to snap is invariably the extensor digiti minimi, followed by the ring, then the middle, and finally the index finger.
To stop that saw blade effect, you mentioned Darik's procedure earlier.
Right. Darik's procedure is an excision arthroplasty. You literally cut off the distal ulna, just removing the jagged rock entirely.
Sounds simple.
It is. But the problem is that it can leave the ulnar stump totally unstable, causing this painful clunking.
Ouch. So what's the alternative then?
The superior biomechanical alternative is the Sovei-Kapanji procedure.
Sovei-Kapanji, how does that work?
Here, you actually fuse the distal radial neurojoint, the DRUJ, so the jagged head is locked to the radius. But to maintain forearm rotation, you remove a segment of the ulna shaft just proximal to the fusion.
Oh, I see.
Yeah, this creates a pseudoarthrosis, allowing the radius to smoothly pivot around the fused block without stretching any tendons over sharp edges.
That is seriously elegant engineering.
Yeah.
What about fusing the entire wrist? I always see the Stanley pin mentioned as a robust way to achieve arthrodesis.
The Stanley pin is a very strong intramedullary device, sure, but it has 2 massive drawbacks for a plastic surgeon. First, it fuses the wrist in absolute neutral.
Which is bad because we need wrist extension for a strong grip.
Exactly. The flexor tendons need the wrist to be extended to be at their optimal length tension relationship. A neutral wrist significantly weakens your grip strength.
And the second drawback?
The pin occupies the medullary canal of the third metacarpal. So if that patient later needs an MCP joint arthroplasty, you have a massive metal rod sitting exactly where you need to insert the stem of your silicone joint.
That would be a nightmare. Good to know. And a quick operative pearl here. When we are in the wrist doing an extensor tendon synovectomy, cleaning out that inflammatory tissue, we don't just close the retinaculum back over the top, right?
Correct. You release the extensor retinaculum and you place it underneath the extensor tendons, laying it directly over the raw bone.
Oh, so you're essentially installing a biological carpet over the jagged floor to protect the cables from future fraying.
That's a perfect way to picture it, yeah.
Awesome. Okay, let's translate this to the clinic. I'm examining a patient, and they cannot extend their middle and ring fingers. Now, the tendon could be physically snapped by Von Jackson, like we just said, or the nerve powering the muscle could be compressed. How do I distinguish a shredded cable in the hand from posterior interosseous nerve, or PIN, compression up near the elbow?
That's a great question.
Because if the nerve is blocked high up, wouldn't it look exactly like a snapped tendon down below?
Active extension will look identical. It'll just be absent. But passive testing reveals the truth through the tenodesis effect.
Right, the tenodesis effect.
Yeah, if the extensor tendon is ruptured, mechanical cable is physically severed. So when you passively flex the patient's wrist, the fingers will just remain linked because there's no continuous cable to pull them up.
And if it is PIN compression?
In PIN compression, the nerve signal is blocked by a massive pocket of synovitis at the radiohumeral joint, but the structural cable itself is perfectly intact.
So the tenodesis effect still works.
Exactly. If you passively flex the wrist, the tension on those intact extensor tendons will automatically pull the fingers into extension. The power is out, but the mechanics are intact.
Okay, that is super clear. Let's move to the volar side now, the flexor surface. What is happening in the palm?
Well, the synovitis within the flexor sheaths often clumps into these small, pearl-like masses. We call them rice bodies.
Rice bodies, right?
But the critical structural failure here is the Mannerfelt lesion.
The Mannerfelt lesion, why does that specifically target the thumb flexor?
Because of the scaphoid bone. In RA, the scaphoid develops these really sharp, bony spurs. And due to its anatomical trajectory, the flexor pollicis longus, the FPL tendon, bows directly over the scaphoid.
Ah, so it just rubs right against those spurs.
Exactly. It rubs and then it ruptures. It is the most commonly ruptured flexor tendon in the rheumatoid hand.
What if a deep flexor, like an FDP tendon, ruptures inside one of the other fingers? Do we try to repair it?
Usually no. Repairing an FDP inside a swollen rheumatoid finger risks massive scarring and bulk within the tight pulley system.
So what's the strategy?
The preferred surgical strategy is to simply fuse the distal interphalangeal joint, the DIPJ, and perform a tenosynovectomy.
So you provide a stable fingertip while carefully preserving the superficial flexor, the FDS.
Right, because the FDS does the vast majority of the heavy lifting for grip strength anyway.
Okay, let's look at the fingers themselves. As the wrist foundation collapses, the digits above it inevitably deform. The Anki deck talks a lot about the Z deformity. Now, to the untrained eye, it looks like the hand is just collapsing totally randomly. But it's actually a highly predictable biological adaptation, isn't it?
It is. It's actually the body's desperate attempt to maintain reach and balance.
Really?
Yeah. When one joint adopts a persistent abnormal angulation due to destruction, the adjacent joints are mechanically forced to angle in the exact opposite direction. The bones basically form a zigzag pattern to try and keep the fingertip pointing forward.
So if the carpus, the wrist, starts sliding radially toward the thumb,
The Z mechanism dictates that the joints above it, the MCP joints, must compensate by bending the opposite way. And this drives the fingers into severe ulnar drift.
okay, let's dissect that ulnar drift because there's a distinction made between ulnar deviation and ulnar shift.
Yes, deviation is pure angulation. The finger is simply tilting sideways at the knuckle.
Okay. And shift.
Ulnar shift is a catastrophic structural failure. It is the physical translation or subluxation of the proximal phalanx entirely off the side of the metacarpal head.
Wow. But why do they always drift ulnarly? Why not radially?
That comes down to the anatomy of the sagittal bands, which, centralize the extensor tendons over the knuckles.
Yeah.
Naturally, the sagittal bands are much thinner and weaker on the radial side.
Ah, I see.
So when the rheumatoid synovitis aggressively inflates the joint, it acts like a balloon expanding from the inside. The weak radial sagittal band stretches out first.
And once it stretches, the extensor tendon just slips right off the top of the knuckle.
Exactly. It drops into the ulnar valley and physically drags the finger into ulnar drift.
And to correct that, during an MCP joint replacement, we perform what's called a crossed intrinsic transfer.
Yes. You release the tight, contracted ulnar intrinsic muscles of the index, middle, and ring fingers. And then you physically transfer those tendons over to the radial side of the adjacent fingers.
So you're basically rewiring the tension cables to pull the fingers back to the midline.
You got it.
Amazing. Now, further down the fingers, we have the classic digital deformities, swan neck and boutonniere.
Right. Let's look at the swan neck deformity first. The hallmark posture here is hyperextension of the PIP joint, the middle joint, combined with flexion at the MCP and DIP joints. The middle joint is basically snapping backward.
And NailBuff classified these. What differentiates a type I from a type 2 swan neck?
It all depends on flexibility and intrinsic tightness. A nail buff type I swan neck means the PIP joint is fully flexible, regardless of what position the hand is in.
So you can just manage that conservatively.
Yeah, with silver ring splints to physically block the hyperextension, or you can surgically tether it with a sublimus sling.
And type 2?
Type 2 introduces intrinsic tightness. The ability to bend the PIP joint becomes completely dependent on the position of the MCP joint.
How so?
If you hold the patient's knuckle in extension, the intrinsic muscles are pulled tight like a bowstring, and suddenly you cannot passively bend their PIP joint. But if you flex the knuckle, the tension relaxes and the PIP joint bends. It's a dynamic tethering.
Okay, got it. Now, the boutonniere deformity is basically the structural opposite, right?
Correct. The boutonniere features PIP joint flexion with MCP and DIP joint extension. The middle joint is permanently hunched forward.
And mechanically, that's because the central slip of the extensor tendon has stretched or ruptured.
Yes, and this allows the lateral bands, which normally sit above the joint axis, to displace volarly. They just drop down the sides of the finger.
They're pulled down by the transverse retinacular ligaments?
Exactly. And once those lateral bands drop below the axis of rotation, their whole function flips. Instead of extending the joint, they now act as flexors, just aggressively locking the PIP joint into a bent position, while simultaneously pulling the distal fingertip into hyperextension.
That is wild. How do we interrupt that abnormal tension?
We use a dolphin or Fowler tenotomy. You surgically divide those displaced lateral bands just distal to the PIP joint. This basically severs the abnormal pulling force on the distal phalanx and allows the extensor mechanism to sort of rebalance itself.
Finally, we have to talk about the thumb. I mean, it accounts for half of all hand function, and NailBuff gave it its own complex classification system. What is the most common presentation, and how do the mechanics differ between the types?
NailBuff type I is definitely the most common rheumatoid thumb deformity. It's essentially a boutonniere deformity of the thumb. The MCP joint is flexed, and the interphalangeal joint is hyperextended.
How does that mechanical collapse differ from, say, a type 3?
In a type 3 deformity, the epicenter of the destruction is lower down. It's at the carpometacarpal, or CMC joint at the base of the thumb.
Okay.
The CMC joint subluxates, and then that Z mechanism kicks in, forcing the MCP joint above it into hyperextension to compensate.
And type 4?
Type 4, on the other hand, is defined by massive laxity of the ulnar collateral ligament at the MCP joint. It behaves clinically just like a severe gamekeeper's thumb. The joint simply hinges wide open when they try to pinch.
Wow. And if you're faced with a thumb MCP joint that is completely destroyed, totally unstable, and just agonizingly painful, what is the ultimate surgical solution?
Arthrodesis. Just fusing the joint entirely. It is incredibly reliable. It permanently eliminates the pain and provides a rigid, rock-solid post for the rest of the fingers to pinch against. Honestly, the patient satisfaction rate for a thumb fusion in RA is exceptionally high.
What a phenomenal blueprint. I mean, to you, the resident listening right now, this is exactly what separates a test taker from a true surgical architect. You aren't just memorizing definitions here. You are predicting structural collapse.
Exactly.
You're looking at the ulnar slide of the carpus and seeing that saw blade forming. You're looking at a radial deviation and predicting the Z mechanism cascade.
You really have to see the mechanical scaffolding hiding right beneath the inflammatory biology.
Totally. But, you know, it leaves me with one final kind of provocative thought. We talked a lot about how incredibly effective modern biologics are. IL-6 and TNF-alpha inhibitors that literally halt this disease at the macrophage level before the cartilage even knows it's under attack.
They are absolute game changers.
Right. So as these drugs get better and better, catching the biology before the mechanics ever fail, will the next generation of plastic surgeons even need to perform Willie Sauter's winning procedures?
That is the million-dollar question.
Or is complex rheumatoid hand reconstruction just destined to become a lost historical art? It is definitely something to think about. Until then, though, keep actively recalling this material, keep pushing through that MedSync Anki deck, and good luck on the boards.